So since this is a curious case webinar, I wanted to show the cases that came to us with diagnostic dilemmas, and we were thinking, what could it be? Is it a tumor? Is it a thrombus? What is it? What is going on? So the first case that I have here, this is a 50-year-old lady who presented to us with syncope, episodes of diaphoresis and shortness of breath. The patient underwent a PE study. So these are the images from the PE study, which did not show any pulmonary embolism, but there was significant right atrial dilatation and there was right ventricular hypertrophy. So these findings were reported, and then patient underwent a transthoracic echocardiography to further confirm the findings. So which concurred with our findings, the right ventricular size was moderately increased, function was at least mild to moderately reduced, and there was an echogenic mass that they saw in the mid to distal right ventricle that appeared to occlude most of the right ventricular cavity, and the mass also appeared to affect the tricuspid valve closure that resulted in significant tricuspid regurgitation and right atrial enlargement. So, with this information, the patient was sent to us for cardiac MR to evaluate what's going on and what is this echogenic mass that they were seeing on echo within the right ventricular cavity. So this is the axial bright blood image that showed that there was a mass-like thickening.
I'm sorry to interrupt, but we don't see slide 2. We see the whole PowerPoint slides. So I think you need to share the full screen if you didn't.
Oh, is it? So
Yes, here we go. We see slide number 3.
okay, and now can you see the slide? I share it as a slideshow. Can you see the scene that I just played, or is it?
We just
I
see
still
slide
don't.
3.
The slides, yeah, we see the slides.
Not as a slideshow.
Not as a slideshow. Yeah, you can try the slideshow now. I see your. But maybe when you share your screen, you can share your desktop. That's
Okay, let me try
rather than.
to unshare
Yeah.
and then.
Or you can present from. We clearly see your slides. You can even present from the slides, unless you need to show that. Yeah. Okay.
Okay, let me try sharing entire screen.
Okay.
And then let's see if we can make it slideshow.
Okay.
Do you see it as slideshow now?
Yes.
All right, perfect.
Yes.
Thank you for prompting that. So, so this is the axial bright blood image, which showed the mass-like thickening. And is my pointer visible?
Yes.
Yes.
All right, perfect. So this was the mass-like thickening, which was centered in the mid to apical right ventricle. And this is the cine. Okay, it's not letting me play that. All right, there we go. So this is the cine bright blood images where we can see the mass-like thickening that was centered in mid to apical right ventricle, and it extended along the RVOT to the level of the pulmonic valve. So further, we did perfusion imaging to confirm what's going on within the thickening and the apical region, what's happening there. So in the perfusion images, we saw that there was a large filling defect that's centered in the right ventricle, the apical region of the right ventricle, and it occupied significant portion of the right ventricular cavity. The central portion of the filling defect, it showed no enhancement on the perfusion images on the early as well as the delayed phase, and this filling defect was consistent with a thrombus. So these are the delayed late gadolinium enhancement images, and on the delayed phase imaging, it reconfirmed that the central portion of the filling defect remained non-enhancing. There was no significant enhancement within that area that didn't enhance on the perfusion images as well. And then, along with that, around the area of this non-enhancing filling defect, there was this peripheral enhancement that was surrounding that was surrounding the thrombus, and this reflected the thickened, inflamed endomyocardium. And outside this area of enhancement and thickening, there was the normal myocardium. So, this typical pattern of enhancement corresponded to the very well known and very well described double V sign that we see in endomyocardial fibrosis, where there are basically three layers, which are the thrombus, the enhancing thickened endomyocardium, and the normal myocardium. So that constitutes the three-layered pattern of enhancement and the double V sign that we classically describe in endomyocardial fibrosis, and that was leading to that gave the appearance of thickened RV, and on echo it was basically seen as a thrombus, and they were concerned that is it a mass or is it a thrombus which is filling up most of the right ventricular cavity. So with our imaging findings, we were confident that this is a case of AMF, and that is what it was described as. So patient underwent right ventricular thrombectomy, resection of the endomyocardial fibrosis, tricuspid valve repair, patch closure of the pulmonary artery, and then PATH concurred with these findings and confirmed that there was thrombus sitting on top of the dense fibrous tissue, which was basically organized within the right ventricle. Any questions? I'll be happy to take any questions if there are any for the first case, or we can move on to the next one. All right, so we move on to the next case, and this was a case of a 70-year-old lady who started to develop fatigue, chest discomfort, leg discomfort, had hypertension for a few months, and on echocardiogram they saw that there's ventricular hypertrophy with possibility of apical variant HCM, and patient also underwent a left heart cath that showed that there was no obstructive CAD. So she came to us for an MR, and this was the 4-chamber bright blood sequence that demonstrated thickening at the LV apex. So moving on to the perfusion images, here we saw that again there was this triangular area of hypoenhancement at the apex, which was within the region of the thickened LV that we saw on the bright blood sequences. Here we can see on the perfusion images, you can see the area of hypoenhancement which persists within the region of the LV apical thickening. So this hypoenhancement, the thin layer, the area of hypointensity and hypoenhancement that you're seeing was also visible on the early post-contrast lava sequence. So here the bulk of thrombus was not very chunky, and it was very linear and layering along the area of the left ventricular thickening. And we can see this V-shaped area of hypoenhancement, which was noted within the region of left ventricular apical hypertrophy. So this is a delayed post contrast image where we used high TI time, around 500 milliseconds, basically to enhance, to accentuate the area of thrombus, which remains hypoenhancing even on high TI time, because when the thrombus bulk is not a lot and it layers along the fibrous tissue, sometimes within the enhancing fibrous tissue, it may get obscured on our routine LGE images, as you see on the next slide. So these are our regular TI time LGE images that showed that the enhancement was mainly centered to along the subendocardial aspect of the thickened apex, and the subendocardial enhancement pattern was within the area where we saw the thickening. So here again, this was not confined to any particular vascular territory, and also the left heart cath had given us a more reassuring thing that yes, there's no obstructive CAD there. So seeing the pattern of ventricular apical thickening, a layering thrombus, enhancing endomyocardial tissue and normal myocardium, the diagnosis of EMF was suggested and path concurred with our findings. Talking a bit about the discussion for EMF, it's a restrictive cardiomyopathy, which is more commonly seen in the developing world, with higher prevalence in sub-Saharan African countries, South Asian countries, South American countries. The pathogenesis is not very well understood, and it's multifactorial, with multiple factors contributing to the etiology, such as parasitic infections, the living conditions, socioeconomic status, the genetic predisposition, and all of them together can trigger an inflammatory immune response that results in a profibrotic state. And hence, we see the fibrosis that's centered within the endomyocardium, resulting in our characteristic features that we see here, that is apical obliteration, valvular involvement, because of which there's valvular regurgitation resulting in atrial enlargement, and overall a restrictive heart failure picture. So this is a article from Radiographics that has very nicely summarized EMF, and this is a table that shows the pathogenesis and the etiologies that are thought to contribute to the endomyocardial fibrosis. Imaging wise, if we are able to diagnose it nicely on our MR and give a prompt diagnosis, it can for the treating physician, and it's characterized by an apical filling of the fibrotic tissue involving one or both ventricles. And along with this fibrous tissue, there's a thrombus that forms overlying the fibrous tissue, and then there's involvement of the valves resulting in valvular regurgitation. And we see the typical symptoms of restrictive heart failure. As we already discussed, the enhancement pattern is classically described as the double V sign within the apex, where we see a three-layered appearance, which consists of normal myocardium, enhancing endomyocardium, and then the overlying thrombus, which can be with or without calcifications. If we have a CT, that helps us to confirm that, okay, that's a calcified thrombus, which is layering in the area of fibrosis. And as echo is very readily available, it's basically the first modality, and we get some basic information with it that sees an echogenic mass or an echogenic structure filling up the ventricular cavity. And with all that information, patient comes to us for further workup. So this is the pictorial depiction of what it does to our ventricles. Basically, it leads to the apical obliteration with a double V sign. The ventricles have a shrunken appearance. The valves get involved. The papillary muscles fibrose, and that results in valvular regurgitation, enlarged atria, and overall restrictive heart failure kind of physiology in these patients. Clinically, these EMF presents as an acute phase, and it can present with, and then later on in the chronic phase, the clinical presentation varies, and the acute symptoms In the acute phase, they're very non-specific. There would be like dyspnea, there's periorbital edema, and then patient undergoes an ECG where they see the low voltage QRS complex, ventricular depolarization abnormalities, and then there's non-specific findings. There could be pericardial effusion. And in the chronic phase, once the fibrosis sets in well, it results in restrictive heart failure symptoms. And we can see AV blocks and right bundle branch block, AFib, and also with our imaging wise, we can see cardiomegaly, which is with predominant biatrial enlargement, pleural pericardial effusions, and then features of pulmonary hypertension. There are various subtypes that are defined, and biventricular one is the more common subtype. The first case that I showed you actually had a it had a strand of fibrotic tissue within the left ventricle as well, so it was classified as biventricular. The biventricular is the most common subtype, and then comes the isolated right ventricular involvement, and the less common one is the isolated left ventricular involvement. This is a tabular representation of how imaging helps us to diagnose EMF. One thing that has been discussed and has been studied is the prognostic information. What prognostic information can we get with our cardiac MRs? So, what we are trying to do is we are trying to quantify the degree of fibrosis. And with the increasing amount of apical fibrous tissue deposition, which is indexed to the body surface area, and if it is more than 19 ml per meter square, then that has been directly related to worse functional status and higher mortality in these patients. So quantification of fibrous tissue can also help us in giving a prognostic, adding a prognostic value to our to the findings, and also guiding the treating physician as to what the next step should be. When we see such cases, we always have multiple differentials to differentiate these conditions from, and the most common one that the probable diagnosis that comes to us is apical HCM, because hypertrophic cardiomyopathy, which is involving mainly the apex, on echo, even that presents as apical thickening, asymmetric apical thickening, and the patient basically presents to us for further workup. I have the cases to show how these differ, and then we can discuss one by one how EMF differs from these differential diagnoses, which includes apical HCM, apical thrombus formation, non-compaction cardiac amyloid, or if there's any neoplasm, which can have multiple variable manifestations. So this was another case. This was a case of a 63-year-old gentleman who presented with dyspnea, shortness of breath, and had an echo. And the echo showed that there was basically left ventricular thickening that was centered along the apex. So, with this information, patient was sent to us for cardiac MR to evaluate for further workup. So here what we see is basically this is a 4-chamber bright blood cine that demonstrates the apical predominant left ventricular hypertrophy, and has a very classic defined configuration, which is known as the spade-like configuration that we see on this 2-chamber view. I have the, a diagrammatic representation of a spade that kind of fills into the left ventricular cavity. And this does correspond to that shape of a spade. So that's why it's classically described as a spade-like configuration of the left ventricular cavity where the apex is thickened. So these are the post-contrast LGE images where we can see the LGE is basically centered within the area of hypertrophied apex, and on our semi-automated quantification method, we saw that the LGE involved around 10% of the myocardium. As we all know, we need to quantify the amount of LGE because the functional status based on EF, based on LGE quantification, the further management differs. So here, differentiating this from EMF, there are certain features which are, we saw that there are morphological differences, that here the apex basically has a spade-like configuration. The LG is centered within the area of thickened apex rather than being more endomyocardial, it is more myocardial. And also the functional features which help to differentiate these two entities. The most striking functional difference is the apical obliteration that occurs in EMF, that's seen in both systole as well as diastole, whereas in HCM, the obliteration is mainly in systole. So that abrupt obliteration that happens of the apical LV cavity and persists in both systole and diastole is seen in EMF. Whereas in HCM, it's a gradual obliteration of the left ventricular cavity from the mid cavity to apex, and it's mainly described in systole. So, apart from the morphology, the functional features also help us to differentiate these two. Um, any questions so far? Or are the cines visible now? Or is it just showing us stack images?
It shows a single image,
So
stack of like a
the
stack of
cines are
sheet,
plain, right?
three-chamber view and four-chamber view.
Yes. Okay. So this is the another case where these are basically, I'm trying to show the differentials, the conditions that we commonly, once we see EMF, the things that we have to think of that could be other than EMF. So this one, the first image basically shows us the four chamber view where the LGE is more transmural. It's confined to the LAD territory, and along with the LGE, there's this layering thrombus. But here, the layering thrombus is lying on an area of transmural LGE, which is in an ischemic territory. So, this is basically a thrombus that's associated with infarction and does not fit into the criteria of the LGE pattern that we saw for EMF. The second image, this is a differential, which is basically a case of a DCM, dilated cardiomyopathy, where the thrombus was formed within the dilated ventricle, but there's no abnormal endomyocardial enhancement, which we would expect in a case of EMF. So then this is the classic picture of non-compaction, where we see a hypertrabeculated left ventricular cavity, and within these trabeculae, sometimes because of slow flow, a thrombus can form. But the picture is very different. Clinically, it would also present in a different manner. So we have multiple supporting uh, uh, evidences to differentiate the two conditions and come up with a more accurate diagnosis. This is a case of amyloid, but amyloid would present with a more diffuse subendocardial to mid myocardial, sometimes transmural LGE, and there would be restrictive cardiomyopathy picture. And overall, the clinical and the imaging features are not very, very overlapping for EMF. So overall, if we are able to, the idea here was because EMF, it depends a lot on the clinical profile of the patient, where the patient is coming in from, what are the exposure factors, any history of parasitic infections. But overall, if our with our MR findings, if we are able to give a nice quick diagnosis, then it can give a nice anatomic insight to the person who's to the treating physician who needs to, and help them in assisting the surgical planning, and also play an important role in differentiating it from the other cardiomyopathies and facilitate an early diagnosis and treatment of this condition. Any questions? I'll be happy to take any questions.
Nice case and discussion. Thank you.
Thank you very much.